They're still setting up the next case in the cath lab, so we're going to take one of our talks from the tricuspid session. And it's great to have Paul Sorajja here from Abbott Northwestern, who's really one of the leaders in the tricuspid space, and he's going to talk about how we interpret tricuspid TEER trials and registries.
Thanks, Paul. Thank you, Greg, and good afternoon, everyone. First, want to thank Gilbert and the course directors and Greg and everyone for the opportunity to be here in New York. It really is fantastic, and I've really enjoyed the meeting. So when we talk about tricuspid TEER, there are essentially two bodies of evidence that we really look to glean an idea as to what we can learn about this therapy in our patients. And the two bodies of evidence are the Triluminate pivotal trial, which consists of a randomized arm and a single arm, and the B-Right post-market study, which is an evaluation in the EMEA of the TriClip system after its approval there in 2019. And so if we focus on these two areas of evidence, I think we can actually learn a lot about where we are and hopefully where we're going to be going with this therapy. So I was asked to talk about interpretations, and interpretations are always these vague connotations of how we feel about things. But I will tell you, at least my interpretation, the first one I'll share with you, is that there is a pretty good, excellent, and safe TR reduction that we've seen with the TriClip system. And so this is evidence of that. Here we have on the left the pivotal randomized arm, in the middle the pivotal single arm, and on the right the B-Right real-world registry. And we can see that in each of these studies, the TR reduction to moderate or less was excellent. It was 80 to 90%. And I'll just highlight that in the middle here, the pivotal arm for the single arm Triluminate patients, those are patients in whom they were placed into that arm because the operators, who are all expert, Anita Goggin are here in front of me, I'm one of them too, felt that these patients would not get to moderate or less. But in fact, we actually exceeded our expectations. We were wrong 80% of the time. So in fact, a lot of them got to moderate or less. And then the other thing about this TR reduction is that this is in the background of some of the most extreme pathology in terms of TR that we see. Becky Hahn, who's I believe here, taught us about torrential TR being an existent grade for this therapy. And these patients often had torrential TR, and they often had a lot of leads in place as well. So this is an example of some of the anatomy that was treated in these clinical trials. And here on the left, this is a patient who had an extremely mobile RV pacer lead. 2 clips are placed, mild TR. Here's a recent case example also from our hospital. You can see here in the middle, multiple leaflets or segments, however you wanted to term them, multiple different coaptation planes. I like to describe this as a starburst of coaptation planes. Think of how you would want to try to put this valve back together. Well, it's possible with the TriClip system, even with the heart being horizontal like this. This is a horizontal heart, and the TR is mild. And the other thing about the TR reduction is that this was observed in a relatively early experience. The median number of cases per site in the randomized trial was a total of 2 after the roll-ins. So think about that for a moment. 2 cases in these results. And so that TR reduction is remarkable not just because of what we saw in terms of the effectiveness, but also because of the safety. So here are the 30-day adverse events for the pivotal randomized arm, the single arm, and the B-Right post-commercial approval study. And if we look at all of the important event rates, they're all in the single digits. And in fact, a lot of them are plain zeros. This is a very safe therapy. And for the event of permanent pacemaker, think about this for a moment. A right-sided intervention near the tricuspid valve, essentially a 0% pacer rate. So a very safe procedure. So that's first interpretation. Interpretation number 2. Again, these are just opinions, feelings about things, but my interpretation here is that there was no effect on early survival, but we probably shouldn't have been expecting one to begin with. And so let's talk about that. So in the randomized trial, we know that we look at the initial cohort of 350, and now I'm sharing with you all 572 randomized patients. There was no difference in survival or tricuspid valve surgery. In fact, the survival was already over 90% at 1 year. No difference in HFH either. But what was really interesting in TRILUMINATE was that the one-year mortality was much lower than we thought. 8.6%, HFH less than 15%. These were far lower than what we had powered the study to be because we were just off. And we think about, well, how did we end up in this situation? Isn't TR just really bad? Well, it is in certain contexts. And so I asked you to look at these studies over here in orange. These are the studies that were around when we were planning TRILUMINATE around the year 2018. And at that time, when we have TR to any degree, whether it's mild, moderate, or severe, in association with left-sided disease is a bad prognostic marker because it signifies biventricular failure. I think all of us in medical school would agree that biventricular failure is a very poor prognostic sign. And here, undoubtedly, when TR is present, the one-year mortality, 20 to 50%, not a surprise. But when we take TR in isolation, which we have to do in a clinical trial, we have to pull it out of everything else, take away the left-sided disease, and the TR by itself, the one-year mortality rate is very low. So here in blue are all the most recent clinical studies of isolated TR or TR with well-managed left-sided disease. And here, the one-year mortality rates are in the 7 to 14% range, and TRILUMINATE pivotal sits right smack in the middle of that. So the one-year event rates are much lower than expected. At least right now, we would need a much larger study with extended follow-up to demonstrate any survival benefit if there were to be one to be found. So interpretation number 3, and this is my final one here, is that the quality of life benefit is meaningful. And this is an important thing to cover because we know that in the clinical trial of TRILUMINATE that the device demonstrated superiority based on quality of life alone. It was quality of life that drove the primary endpoint, and it was a quite significant quality of life improvement. In fact, this is what Suzanne Arnold presented just a month ago at TCT. And what she has here, she has patients who are alive with moderate improvement, alive with large improvement, or alive and well. If we look at it from a number needed to treat standpoint, the device does really well, 3 to 5 for an NNT to achieve meaningful clinical benefit in quality of life. Now, certainly, this is a patient-reported outcome. It's subject to some degree of bias. We know that these patients were not blinded. And in every clinical trial, when it's an unblinded study, there's going to be some degree of some type of placebo effect. So what evidence might there be that this might not be a placebo? Well, it's challenging because the trial's done. We can't take it back. It is what it is. But there are a couple of things that are really interesting. So first, when we look at the quality of life improvement of the device over medical therapy alone, look at the degree of improvement here. It's around 15 to 20 points, and that's pretty consistent, not just in TriClip, but also in TriSyn, other tricuspid therapies. These patients can have quite significant improvements in quality of life. We know that that far exceeds the conventional minimal clinically important difference of 5 points. And we also know that the high threshold that was chosen to make sure the trial was a benefit, that this high threshold was met, and there was no waning of the effect that we would often want to see if there were a placebo. In other words, a placebo effect typically has some degree of waning at some point, but this is a really high sustained benefit. So that supports, at least to some degree, that maybe this is not all placebo, that this is actually a high degree of quality of life benefit that's meaningful. And I'll tell you, when the trial was designed, we actually did not think that we could win on quality of life alone because we didn't think we would meet that high of a threshold. So we were all surprised when we did that. The other thing, other two aspects that I'll share with you is that when we look at the exploratory analyses of patients who had devices in the TRILUMINATE trials, is that when we look at the association of quality of life with change in TR grade, it's a very tight relation. You know, certainly patients will know that they got the device, but they may or may not know what degree of TR reduction they got. In other words, the TR is graded in a core lab, and that severity is not always to the patient, but there's clearly a relation that for every grade in TR, there's about a 4-point improvement in the quality of life. The other thing that's really interesting, and this is what I find really provocative, is that when Suzanne looked at all of the device patients, what she found was that if there's a 10-point increase in the quality of life at 30 days, that's associated with a significant reduction in death, HFH, or death plus HFH in follow-up. And this is because she's able to look at all 396 patients, so it's a much larger group. But this is a post-hoc analysis, which is not pre-specified. This is, again, more hypothesis generating, but again, it supports the notion that if we improve these patients' quality of life, everything moves in the right direction for these patients. And then the final thing I'll share with you is that there's really good physiological data that supports that this is not a placebo effect. So this is a patient that was at our hospital, and this is an MRI study that was done by my colleague, Dr. Joel Cavalcante. And we can see here that at baseline, this is an artifact from a pacer lead that was in there. We take the TR from 86 to 2. Yes, he says he can measure 2 ml with an MRI. I'm not sure how he does that, but he does. But it doesn't matter because we know the TR is better and the RV volume shrank. RV went from 237 to 166. Diameter goes from 50 to 44. And this is acute. This is within 30 days. So it's really physiological interesting. And when he looked further at the imaging sub-study, there were 21 patients, so not a large group of patients, but these are randomized patients. And what he saw was that the RV volumes did shrink in the device group, but not in the control group. And I think that's very important. Despite GDMT, no changes in RV size. And going even further, when he looks at the effective RV ejection fraction, which is essentially how much stroke volume you get for the size of the RV, the higher number is the better. There is an increase in the effective RVEF for the device group, but not in the control group. And that's just at 30 days. So again, supporting the notion that this quality of life and what patients are feeling is actually very, very real. So in summary, in terms of my interpretations, there is a high degree of sustained TR reduction. It's been observed in every arm or trial eliminate thus far. It's a very safe trial, less than 1% adverse rates, very low deaths and pacers. Survival is much higher than we thought it would be for isolated TR at 1 year. The quality of life is significant and sustained. It's related to adverse events and post-hoc analyses. And what we're starting to see and understand better, and hopefully more data will come out, is about the actual RV remodeling and other notions that will support that this is an improvement in quality of life that's meaningful. So with that, I'd like to thank you again for the opportunity to be here. It's a real pleasure.